All right, here we are. We're starting our very first live Facebook chat for HCA. Hi, everyone. I'm Amy Blondin. I'm the Chief Communications Officer here at HCA, and I'm here with Dr. Charissa Fotinos, who's our Deputy Chief Medical Officer and Director of Behavioral Health Integration for HCA. Thank you so much for taking time to do this today and doing our very first Facebook Live. Charissa is a board-certified family medicine and addiction medicine physician, and she spent a lot of her career practicing medicine serving people with behavioral health conditions. So she has lived this work in the clinic and is now luckily helping us lead our opioid response at the state level. So Charissa, we want to go ahead and dive in. The first question we have for you is, what is opioid use disorder?
So opiate use disorder, like any other substance use disorder, is a condition where people lose the ability to control their use of a medication. So people think that opiate use disorder is when people's body gets used to a medicine and they stop and they have symptoms. That's dependence, but that's not addiction or substance use disorder. The other thing people sometimes confuse with it is tolerance, where if someone has to take medication, say for a severely broken leg, and they start with pain medicines, over time they'll have to take more medication to have the same effect. That's also not a substance use disorder. What substance use disorders sort of may have in addition, or most importantly, is this sort of incessant craving that sort of takes and hijacks your normal responses and thinking, so that having that drug or alcohol or cigarette becomes more important really than anything else. And as a result, people's lives sort of start to crumble. Relationships suffer. They may not be able to maintain their work. They may resort to doing things that they wouldn't have otherwise done before they actually developed a substance use disorder.
How does an opioid use disorder actually impact the brain?
So opiate use disorders, like some other opiate use disorders, work on the reward system of the brain. And what happens is when someone gets an opiate, there are a couple things: that there are pain receptors, that the pain receptors respond to that pain. But opiates also release dopamine, which is a chemical in our brain that we release when we fall in love or we have a spectacular meal. It's just that sort of good feeling. When you use opiates, dopamine gets released, but in a much larger amount. And so our brains are desired to learn. So if our brains experience something pleasurable, they're like, oh, I like that. I would like to experience that again. But what happens over time is, while that dopamine surge was initially there, over time the dopamine isn't as effective either at being released, and the receptors don't respond in the same way. So what happens is, instead of getting that high, people start to experience the effects of the withdrawal, where they don't have the opiate in their system. They start to feel sick, and then they have to take an opiate just to not feel sick. So what initially was a pleasurable experience becomes really an experience of having to use the opiate to not be extremely sick. That's the craving part. The other thing that happens is the reward system is wired in with our learning, our memory, our behavior, our stress system. And so because we are designed to learn this pattern of behavior driven by this craving, where people really aren't able to deliberately choose to stop or control their use like you might think they should be able to.
Okay. Feel free to submit your questions to us. We are going through some questions that we received ahead of this broadcast. So Charissa, what is medication-assisted treatment? And we hear that a lot as we're responding to the opioid epidemic. What is it, and how does it work?
I think, initially when people started talking about medication-assisted treatment, that was somewhat early on. We know, for instance, that methadone is an opiate. It's an opiate that acts fully on that receptor. Methadone clinics have been around for decades. But they're sort of marginalized. People have sort of put methadone clinics in places that aren't desirable, and sort of stigmatized people who've had to use medication for an opiate use disorder. What we've learned through brain science is that really opiate use disorders alter the way in which the signals in the brain work, and that it's not just a matter of someone saying, I'm going to use opiates today or I'm not. It's really that wiring becomes altered through that reward circuitry that I talked about. And so what the opiates do is sort of stabilize those circuits, better normalize them to sort of prevent the withdrawal, reduce the craving, so that people can, sort of figure out what they need to do to restore their lives, their relationships. And so methadone's been around for a long time. It's a drug that does that. More recently, there's a drug called buprenorphine that is acts partially on the opioid receptor, but not completely, to similarly stabilize people, reduce the craving, stop the withdrawal symptoms so that they can, take the steps they need to improve their life. There's also another type of medication called an opiate antagonist that blocks the receptor. It also reduces the craving, but people have to have completed withdrawal before they go that. So when people first started using medicine, they said, well, it's assisting the traditional treatment. But what the science and the literature has told us is that really the primary and most effective treatment initially for people with opiate use disorder is medication, methadone or buprenorphine, to help stabilize those brain circuits and pathways so people can really do the work that they need to get the help they need to move forward.
Let's talk stigma for a second. My understanding is that there has been some feeling that medication-assisted treatment is somehow less than just stopping altogether.
Right.
Where did that come from, and how are we sort of counteracting that message?
I think, in part it came back from sort of the traditional view of addiction, which when the discipline sort of 12-step program and the programs were formed decades ago really were in large part around alcohol. And alcohol is a substance that people can develop severe dependence or substance use disorder to, and as often as not, stop using and not use again. But what we've learned is different substances work differently on the brain. And unlike alcohol or perhaps stimulants, opiates are not drugs that people can just decide to stop and stop. That said, there are people who can wake up and decide, I'm never going to use opiates again, and they don't. But that's the very small minority. So by applying this sort of judgment that people choose to use, and they continue to choose to use when their lives have been destroyed, they've lost their children, they've lost their family, that's not really true. I mean, so we create this stigma, we create this judgment, and what that does is it prohibits people from seeking care. If they know they're going to be judged and thought of as morally weak or morally wrong, they're not going to go ask for help. And unfortunately, with opiate use disorder, it's deadly. Person's risk of dying is quite real, especially if they've had one overdose. So the stigma is not, it doesn't help in any way. And words I think that are, can convey that stigma are calling people addicts, or talking about people being clean and dirty, or users. And I think that people in recovery can refer to themselves however they want, absolutely. But I think as a healthcare professional, or people in the health services system, we can be more thoughtful about the words we use.
Absolutely. We have a question from Layla. Can you go over the 2018 opioid prescribing requirements for chronic surgical and subacute pain?
So each of the boards and commissions were asked to put forward, and I assume you're referring to the state guidelines. I'm not sure if you're referring to the state guidelines or others, but each of the boards and commissions were asked to put out recommendations for how prescribers should manage people on treating with opiates. And basically they broke it down into new prescriptions and then ongoing prescriptions. I haven't honestly memorized the rules for each of the boards and commissions. They're certainly available online. But I think taking a step back, the idea is opiates are extremely useful. They are good pain relievers. But like anything, in some people, a subset of folks, they are at risk of developing a substance use disorder from that. And so really what we're trying to get providers to do is say, okay, opiates have their role, absolutely. They work for pain. Are they the best treatment for chronic pain? Maybe in a subset of people they are, but in other people they may not be. And so these rules are meant to sort of have prescribers pause and say, okay, let's look at the risks and the benefits, the other medications this person's on. And you're not going to withhold opiates for someone who might have a fractured leg or arm that you want to relieve their pain. But we also know that the longer people are on an opiate, the higher their risk of continuing that for a year and longer, the higher that risk is. So we want to be mindful about how we're prescribing, how much we're prescribing, and making sure that really that is the best treatment option for the person at that time. And so the rules and regulations, again, are available, and they differ slightly by the profession.
Great. We have a question from Monica. Can you talk about youth and medication-assisted treatment?
Right. So there are more studies that are coming out recently that suggest that youth certainly benefit from medication. Most people don't really want to prescribe methadone to youth, in part because the age that methadone clinics have to operate with is 18 and older. But also methadone is a complex drug to prescribe and can have a lot of interactions with other drugs. And it wouldn't be necessarily the most therapeutic to have a teenager at a methadone clinic in some circumstances. So a lot of people are using buprenorphine and finding that it is helpful. In Washington, we certainly allow anyone 16 or older to be treated with buprenorphine in terms of that's what the drug is safe for. And if the provider, the prescriber, is working with a youth who is in serious trouble, has a serious opiate use disorder, maybe injecting opiates, and that person is younger than 16, that provider may work with that youth and or their community, family, whomever, to decide that that is the best treatment for them. But it does appear to be effective in youth, and we want to help however we can.
Okay, great. Thank you. We have a question from Shannon. She says, first, thank you for all you do to teach us about this brain disease. Okay. You mentioned a while ago that there was going to be a one-stop place where people can call and find treatment facility availability instead of having to call each place themselves. What's the status of that?
Right. So the good news is it's the Recovery Helpline. That was just launched in its new and improved version. You can call the Recovery Helpline number, or you can go online and actually plug in your zip code and look for providers around you based on what you're looking for, and have much more ready access to treatment, and whether that's treatment with medication someone's looking for, or more traditional or typical outpatient, intensive outpatient, or residential treatment. So Recovery Helpline, remember that. You can find the number online, and you can look online and plug in where you are to see what's available near you.
Great. A comment from Mandy: thank you for teaching compassion and kindness. It's the most important part of healthcare. Not a question per se, but it does beg the question for me at least, is compassion and kindness really the prevailing attitude among providers when it comes to treating opioid use disorder? I mean, is that kind of the fundamental worldview?
No, I mean, no, it's not been, honestly. I think that, the medical community, and when I say medical community, physician community, I think is getting better about teaching medical students and residents about substance use disorder. What I didn't say that is sort of a big miss, and I want to make clear, substance use disorders are medical conditions. They are chronic medical conditions, much like diabetes or high blood pressure. We don't withhold medicine from people who have diabetes because they splurged and ate ice cream and cake, and their blood sugars are out of control. We don't say, well, you clearly don't want to manage your diabetes, so I'm never going to see you again. But we've not really put substance use disorders in that same mind frame of this is a chronic condition that people may well relapse on and struggle with the rest of their life. Some people don't, but many people do. So really thinking about it as how do we better manage chronic conditions? Well, it's understanding, it's listening, it's compassion. I once heard a psychologist who's written a lot of books on motivational interviewing. He's sort of nationally famous, of course. I can't remember his name at the moment, but in his research that he's at the University of Washington, he said two of the best predictors about people getting into recovery and staying there solid are empathy with their provider, whomever they identify as that helping person, and hope. If people don't have hope, they don't, why get up in the morning? So I think that compassion is important, and not just from providers, but from really anybody who interacts with someone with a substance use disorder, and understanding they didn't choose this. This is a chronic condition that this person struggles with.
Thank you. Question from Janice. Hi, Janice. I know you. Many individuals have the belief that clinicians are now cutting people off. Sorry. Let's see. Something popped up, so now I can't see the question. Cutting people off of dosages for chronic pain of opioids. Do you think is that happening?
I think, unfortunately, in certain cases that has happened. Mm-hmm. And I think that, I wish that it's true of all things in life, right? You wish you had all the information you need before you decide what you're going to do. And I think that as people became more aware of the opiate epidemic, which did really start with prescription opioids, people started deciding, well, it's providers, it's doctors, it's nurse practitioners, it's physicians assistants who are prescribing too many opiates. They caused this, they're bad. And then as people sort of peeled back that information, they said, well, maybe it's the drug companies. Well, it's a lot more complicated than that. So, but all doctors heard was they caused this epidemic. They caused more deaths than anyone else. And so what's the prescriber's reaction to that is fine. If they're bad, I'm not prescribing them anymore, which is not exactly what we want either. And then as more rules and regulations got put in for providers to sort of act as prompts, some became very frightened and just said, it's not worth it. I'm not going to manage this. So in some cases, people have unfortunately been stopped on their medications. And it's our job as providers to better educate both providers and folks using healthcare systems that there is an appropriate time and place for opiates. There are cases in which they do work for people long term, and that really, we're not trying to get people in trouble. We want folks to be able to take the time and get the information they need to best address someone's pain or discomfort and keep them safe.
Another question, can drugs' influence on the brain make people do things they wouldn't normally do if they weren't under the influence?
So in a way, yes. Substances impair a person's judgment, and you can't really predict what someone's going to do. People have this perception of folks with opiate use disorder as, the folks are all, doing criminal behavior. None of them tell the truth. And part of that craving, desire that I must do this, and if I don't, I'm going to be horribly sick, does lead to people making choices that they might not otherwise make. And that may include stealing from friends or family, or, doing criminal acts that they otherwise wouldn't do. It's not that they want to do them or they want to harm people. It's that their disease is so bad and so much a part and in front of their whole life that is where they get. If you think about, if you've ever seen someone intoxicated from alcohol, people respond differently to alcohol. Some people get giggly and silly. Other people want to go pick a fight. And so alcohol and substances affect our brains differently. But for folks who use chronic opiates, as I mentioned, that reward circuitry is involved in learning and memory and stress and behavior. And part of all those are in the front part of the brain. That's where our critical thinking skills are, our judgment and our decision making. So as the dopamine pathway sort of gets exhausted, the sort of counter pathway builds up and impairs those ability. I think an important thing to point out is this is particularly true in youth. In teens and young adults, their capacity, their front lobe, that judgment, that sort of behavior modification or awareness hasn't completely formed yet. So if they're exposed to drugs or alcohol in that sort of critical brain development stage, and they don't have the opportunity to get those sort of circuits wired and solidified, then it puts them at even more risk if they're using drugs or alcohol young, of never being able to fully develop those skills that as we age into adulthood, we get.
A question from Melissa. Is there a recommended amount of time someone should stay on medication-assisted treatment?
That's a great question, Melissa. I think that the best that we know from the studies that are out there looking at long-term outcomes, which arguably are 6 months to a year, maybe more, is at a minimum, people should probably stay on medication. And I'm speaking more specifically about buprenorphine for 6 to 12 months. And I think that, people talk about medicine as being an art and a science. And I think in my experience working with patients, what I've learned is that everybody's a little bit different. And so part of it depends on how well someone's doing. We do know that if people are stopped on their medication within a couple weeks or a month, their likelihood of returning to use of opiates is about 90%. So we know that short periods of time don't really help folks the way they need. Maybe 6 months, maybe 12 months. What I found helpful in my practice is really talking with that person, understanding what their goals are. And if someone comes into me and says, I'm tired of being on my medicine, I really want to do this without medicine, certainly we're going to have that discussion. But the things that I want to know about in that person's life are, well, Do you have a safe place to live? Is your housing stable? Do you have a community of support? If you weren't able to have your kids with you for a while, do you have them back now? Are you able to get out and look for work if you're able to, or not? And if the answer to all those are no, then I would honestly say to that person, it may not be time yet to go off those medications, because we know they're, managing the craving. They're in large part, that's the main thing, several months out. And so it may not be the best time to do it. I would never tell someone no, but really a lot of the behavioral work that also has to happen in addition to medication is sort of what might have triggered that use. Did someone have old trauma? Do they have PTSD? Was there depression or anxiety that hasn't been treated? Was there some traumatic event that needs to be worked through? So once people are stable on medicine, that's when all those other things can be addressed. And when people get to a place of stability in managing that, and maybe they have another substance use disorder as well, maybe they have a methamphetamine use disorder or an alcohol use disorder, if they also need sort of more traditional treatment to augment their medication to help address those, then that's important too. So really it's a matter of, is it the right time? Is your recovery solid? Are you stable? And is it the right time for you to go off this medicine? And some people will be on it for the rest of their lives, and that's fine. It's just like people with diabetes. If they're on diabetes because their weight is too much and they lose weight, sometimes those folks can stop their medicine and sometimes they can't. So it should be an individual's decision between that person and their prescriber.
Okay. What are some things people can do to help reduce stigma of substance use disorder in their communities? And first of all, when we say stigma, what does that look like in communities,
right,
from your perspective?
So I think stigma is, for instance, we know in a couple parts of the state that people are trying to reduce efforts to get people clean syringes. And that's its own controversial thing. But really what we know is that people who have severe substance use disorders are using their substances through injection. Their risk of getting hepatitis C or HIV, if they're sharing needles, is quite high. And so the idea is, well, let's help folks reduce their risk. And if they interact with other people, kind of like immunizations, if we reduce the risk in the population at risk, then we spread that out further. So I think stigma looks like, people going around talking about addicts and junkies and saying, well, folks should just be thrown in prison and jail if they choose to use. They're morally weak. And really, I think that if we can all better understand what substance use disorders are, understand that they're chronic conditions, that nobody wants to be homeless in jail, thrown up, curled up in a ball in the corner of the room because they wanted to end up there. They don't. And so really having some compassion and empathy and talk to folks, right? We have this mindset when we think of someone who's got a heroin user, everybody has their own mindset of that. I've taken care of folks who use heroin who work every day. I've taken care of folks who have a heroin use or an opiate use disorder who were living in the alley, and when they got stabilized on medication, they have a job, they got their kids back, they have a house, they're thriving. So it's all true. But just like we shouldn't judge anybody by a name or a label or a perception, these are folks. And I think if communities could sit down and understand, the most powerful stories I've heard in the last 5 years have been in people in recovery who tell their stories, and they're brave, and they get up and they tell their stories about, they were star athletes in high school, or they were, going to the prom, or they had a successful business and a successful career, and maybe they had an injury and they took opiates and they developed an opiate use disorder, and that all came crumbling down. So I think really understanding what's underneath the substance use disorder, it's not a choice, that people had a life before, and they can certainly get treatment, recover, and have that same kind of life if they're treated appropriately. And that stigma just keeps people from seeking treatment. People may want to get help, but if they're afraid to be judged, then they don't. And that just puts them at risk of a lot more harm.
Okay. A question from Matt. One of the most frustrating things I experience is when folks have made up their minds that addiction is a choice and not a disease, comparing it to quitting smoking cigarettes. what would you say to the subset of people who aren't open to new information or a more compassionate mindset? How do we help people understand that suffering individuals want to get better?
I think that, just to sort of reframe it, if you look at addiction potential, there are a number of factors that go into, but why are some people going to develop substance use disorders and others aren't? About 50% of a person's likelihood of developing a substance use disorder is genetic. The other is their environment. What was their environment they grew up in? And not everybody with a substance use disorder grew up poor in a dangerous environment. They grew up in loving families with two parents and more than a middle class income and lots of friends. So environment is part of it. And then the other part of it is development. We talked a little bit about adolescents versus adults. But again, I'll go back to the example of alcohol, or say that when I treated someone with a broken bone with an opiate. Some people would come back, they'd bring me their bottle and say, I hate this stuff. It's terrible. It makes me feel terrible. Either I threw up, I itched, or I don't like how it made me feel. Other people would bring their pills back and say, I was not in control of my thinking. I hate it. Don't you ever give me these again. And other people would come in and say, can I have more? That really made me feel good. That last group of people are folks who have a vulnerability for an opiate use disorder. It doesn't mean they're going to develop it, but it means that there is something innate about their genetics, their makeup, there's something that they are at risk. And so I think that recognizing that we're talking about a small subset of people who use opiates that develop opiate use disorder, but we can prevent that. We can be thoughtful about how we prescribe. And so I think not again, generalizing that all that we've seen on TV or read in the papers is true. And I think that, as I'm sort of talking out loud, I think one of the things that we can also do is educate the media, not just ourselves and our community, but educate the media about the use of proper language. One of the questions that I answered earlier was from a very brave parent who lost her son in the opiate epidemic. And she has testified in front of the governor and our legislature, and she is a powerful advocate for parents. And so I think it's not even so much hearing from me, it's hearing from people whose lives have been affected. And they've either lost family members, friends, or they've seen their family members and friends recover. And so I think, like everything, there are at least two sides. So don't rush to judgment. Be curious, ask, learn, try to understand. I think that's a better place to start a conversation than just deciding that we know the answer.
I've heard that many people are first introduced to opioids by taking somebody else's prescription that's maybe unlocked in their home, and kids, access their grandparents or parents' medication. What are some practical things that people can do with their unused opioids once they're done with them? So
I think that, again, kind of like Recovery Helpline, remember, takebackyourmeds.org. That's a website that you can, like the Recovery Helpline, put in your zip code and get a list of places where they have drop boxes. In King County, a lot of the pharmacies participate. Some community health centers have drop boxes, some police stations. And so really finding out where those are. And then for folks that live in the eastern part of the state, as well as western, there's a National Take Back Your Meds Day, and that's April 26th, I believe. And so there'll be a lot of public information about where you can take medications in your area. I think the thing to remember is, if you go in for a minor procedure or your child goes in to have a tooth pulled, the first question is, does this really need an opiate? If I have a tooth pulled, do we really need an opiate? When little kids' teeth fell off, we don't take them to the doctor for opiates. We're like, oh, here comes the tooth fairy, right? So I think, do we, one, really need that opiate? And then do we need 30 or 40? Probably not. We might need them for a day or two. And then, so helping providers not give you as many, saying, doc, or provider, is there something else I can take instead of an opiate that would help my pain? Often there are equally effective medicines for moderate to severe pain in people. And then really don't save them for the next time, because we know that, per your statement, a lot of folks who start using or misusing opiates find them left over in somebody's cabinet or drawer.
Okay. A question from Lizzie. Do all prescribers use the prescription monitoring program database? Some seem not to check it. First, can you explain what that is? And we're almost out of time, actually. Time flies. What that is and how providers are using it.
So the prescription monitoring program is a registry that the state has where every controlled substance, which would be things like opioids, Ritalin, or treatment for attention deficit hyperactivity disorder, or benzodiazepines, Valium-type drugs are put in there, so you can kind of track where the controlled substances are being prescribed. Doctors right now can look into that two ways. One is you can log into a website, but it is cumbersome and clunky. And if you're about to see someone or trying to write a prescription, it really takes a lot of time that is just not useful for that patient interaction. So it used to be that queries or providers or their staff asking to see if someone was on opiates or making sure that they weren't prescribing something that would be problematic. There were committees, or some of the electronic health records started to be able to just bring the prescription monitoring program information from the Department of Health directly into the electronic health records, so they didn't have to log in separately. And at the end of last year, with the systems, health systems that have been able to do that, we know that at the end of last year, there were 20 million queries to the prescription monitoring program in our state, which is the second most in the country. That's before it was required. And that's way more, well, I don't know, way more, but that's more than the number of controlled substances. So we need to do a better job helping prescribing providers get that information in an easy way for them, so they can be the most informed about what they're prescribing and the safety for their patient.
Okay, great. Charissa, thank you for taking
You're
time
welcome.
to do this.
Yeah.
It's always so interesting to talk with you. In the comments, there is a link to the Washington Recovery Helpline. Please do take a look at that website, and the phone numbers on the website as well. Also, getthefactsrx.com is a great resource for anybody who's going through this themselves or wants to support others in that work. So thank you all so much for joining and submitting your questions.
Yes, thank you.